Hello, I'm Dr. Russell Barkley, and I'm a clinical professor of psychiatry at the Virginia Commonwealth University School of Medicine here in Richmond, Virginia. Welcome to this lecture on issues in the transition to adolescence for children and teens with attention deficit hyperactivity disorder, or ADHD. It is my goal in this short lecture to discuss with you the nature of how ADHD may change over time, particularly at the developmental transition to adolescence, to review with you various areas of impairment that may arise in major life activities during this transition, to consider the implications of these changes both in symptoms and in potential impairments, and what may need to be done about them, and then of course to offer some suggestions to you on how to address these particular issues at this crucial time of the transition between childhood and adolescence. So let's begin. First, what is ADHD? Well, very quickly, we know that ADHD, as defined in the DSM-5 criteria, is a developmental, specifically a neurodevelopmental disorder that consists of delays in two dimensions of neuropsychological functioning. These dimensions are often referred to as inattention or hyperactive impulsive behavior. But research demonstrates that the difficulties are much broader in terms of psychological functioning than those terms seem to suggest. For instance, the inattention dimension probably reflects difficulties with executive functioning, particularly with metacognitive deficits of self-awareness, working memory, organization, and planning and problem solving, just to name a few. Whereas the hyperactive impulsive dimension appears to reflect a broader problem with executive or willful inhibition of behavior. And it has come to include problems with emotional impulsiveness and poor emotional self-regulation, even if those difficulties are not mentioned specifically in the DSM-5 diagnostic criteria. Now, as the DSM-5 points out, ADHD often arises early in development, although that is not necessary for clinical diagnosis. It is often commonplace. Many times the symptoms arise, particularly in boys, before entry into school or at the time of entry into formal schooling. Up to 2/3 of all cases of child ADHD have typically arisen by about age 7, and about 93% of them seem to have arisen by ages 12 to 16. But overall, if we average together research on the onset of ADHD across different age groups, including adults, the mean age of onset is approximately age 12. So although the DSM-5 requires that the onset be before age 12, I recommend that clinicians not pay much attention or give much importance to that number, that instead we are looking for an onset sometime during the developmental period, perhaps up to ages 18 to 24, realizing, of course, that an individual's recall of the age of onset of their symptoms, or the recall of their parents about the onset of their symptoms, is so unreliable as to not be worth including in diagnostic criteria. But in any event, most cases will have developed sometime before 18 to 24 years of age, and those that develop later often occur as a consequence of neurologic injury or other problems that disrupt the functioning of the brain's prefrontal cortex and its executive circuits. These symptoms are developmentally inappropriate or excessive for the individual's age, occur across multiple situations rather than one specific situation, often lead to a great deal of impairment in many different life activities, and lead to a reduced quality of life, these symptoms are not better accounted for by another disorder, and the new requirement in the DSM-5 is that clinicians must corroborate what patients tell them through other individuals who know them well or other sources of information, such as archival records, such as school reports, for instance. This was included because there is some degree of unreliability and underreporting of symptoms by people with ADHD up through young adulthood. And in order not to miss the diagnosis based entirely on self-reports, it's very important that clinicians seek out information from other sources. Now, the symptoms of ADHD may start out looking very much like the classic symptoms described in the DSM-5, problems with distractibility, inattention, gross motor hyperactivity, as well as problems with verbal impulsiveness. But in addition to that, there are problems emerging in the brain's executive functions. Researchers believe that there are at least 7 major executive functions. These would be things like self-awareness, inhibition, working memory, both verbal and nonverbal, emotion regulation, self-motivation, and self-organization, along with planning and problem solving. These major deficits begin to emerge and expand over time as we move into adolescence, such that by adolescence the motor hyperactive symptoms may be declining significantly with age, and indeed may even lead to patients reporting a sense of internal restlessness or subjective restlessness rather than overt gross motor overactivity. And certainly by adulthood, the symptoms of hyperactivity are not of much diagnostic value. In their place, we are seeing the emergence of the difficulties with executive functioning and the self-regulation that such executive functions provide us. And again, we can expect to hear complaints about difficulties being self-aware of one's behavior and problems, difficulties with inhibition, including emotional inhibition, problems with self-motivation, and as I said, difficulties with organization and problem solving, among others. These will become more and more commonplace complaints in the reports of family members or teachers about the teen with ADHD than will the more classic symptoms of hyperactivity that were more characteristic of very young children with the disorder. Some research seems to suggest that although the DSM symptoms of ADHD may be declining somewhat with age, particularly the hyperactive symptoms, as I've already mentioned, that there is an increase in some symptoms, particularly the problems with executive functioning, as the child transitions into other school environments, such as going from a small elementary school classroom into a larger middle school or high school where there are many more students, classes, teachers, and a greater need for self-control, organization, and time management. Thus, while ADHD itself may not be worsening in its traditional symptoms, it may be broadening in its effects on self-regulation and executive functioning. And more importantly, it may become more impairing as the teen enters new major life activities or acquires new responsibilities for self-regulation that were not present during earlier stages of childhood. And so it's not uncommon to hear renewed complaints about problems with functioning in the teen with ADHD as they move on to new, larger, and more complex school environments. Some studies are beginning to suggest that females with ADHD or those with borderline or marginal symptoms of ADHD may become more symptomatic as we see changes in female hormones emerging during sexual development, and particularly at the onset of menses and at the monthly periodic recurrence of menses. The balance of estrogen and progesterone has been shown to influence the severity of ADHD symptoms in females. So we might expect to hear complaints of ADHD symptoms anew, or a worsening of ADHD symptoms in females already diagnosed with the disorder at around these times in their onset of menses and their monthly cycles. Of course, this also suggests that later in life, particularly during menopause, we may also see another worsening of symptoms with that transition. These disruptions in symptoms in females may require altering management approaches to address the problems occurring around these times of their life and these times of the month. We also need to understand that the inattentive and the broader executive function symptoms have a greater impact on school performance than they may have on out-of-school functioning. And that impact clearly increases with age, such that the more severe inattention was earlier in a child's life, the greater impairment we expect to see in academic functioning years later. Now, over time, the different symptom dimensions of ADHD predict different risks and outcomes, and time doesn't permit me to go into all of the details of these risks, only to point out that while inattention and its related symptoms of working memory and poor organization and planning may affect school performance, they also can have some effects on non-academic functioning, as you see here, such as when children and teens are out in the community around dense automobile or other vehicular traffic, or when they are driving, for instance. We may also see them pose greater risks for crashes as the individual teen begins to become a driver, that is, begins to be trained in the operation of motor vehicles. Inattention has been found to also be related to the acceleration of nicotine experimentation. And, of course, the impulsivity dimension may predict impulsive use of these and other substances as well. And as you can see here, the inattention symptoms can certainly affect the teen's performance at home when they have chores or other responsibilities to do, including homework, as well as in their performance in the employment setting should they take on part-time or full-time employment. Finally, we also see more limited self-monitoring related to these inattention symptoms, and that could impair social situations where the teen is simply less aware of the problems they are posing for others than others would be. There are separate risks that are posed by the hyperactive impulsive dimension. Impulsivity, as you see here, is related to a whole host of various risks for impairment in a variety of domains of major life activities. And so it behooves us to pay attention to the degree of impulsivity because its effects can be life-threatening outside of school, and even if not life-threatening, can be very impairing in other domains than just in academics. Lastly, as I've said, impulsive emotion and poor emotion regulation are also part of ADHD, and these deficits will predict impairment in a variety of other contexts than the ones predicted by inattention or hyperactive impulsive behavior. And you see some of these impairments that are predicted to occur in adolescence as well as in adulthood as the teen's impulsive emotion and poor emotion regulation begin to affect their functioning in new domains of life that children may not have had access to. Over time, as children enter their adolescent years with ADHD, we will find that 62 to 75% of the cases in follow-up studies are no longer taking medication if they did so in childhood. The reason for non-adherence or ceasing medication are numerous, but one of them is the teen's increasing sense of individuality and wishing to have some influence over their life, coupled with their own belief, frequently, that they may not have as serious a set of problems as their parents have led them to believe. In other words, they may even come to deny that they have this disorder entirely. But for a variety of reasons, there is a discontinuation of medication during the adolescent years in many cases, leading to many teens with ADHD now having their ADHD unmanaged. Unmanaged ADHD can lead to a variety of impairments in adolescent functioning, not just in limited educational success, but greater conflict within the family and greater conflict with others in their peer relationships, often leading to peer rejection. This may lead the teen to start affiliating with other rejected peers and thereby form a deviant peer group. And it is these peers that may influence the ADHD teen into participating in greater antisocial behavior and other illegal activities, as well as in beginning to engage in early substance experimentation, perhaps going on to substance dependence and abuse disorders, as you see here. As the teen becomes sexually active, we may also see an increase in risky sexual behavior that can lead to early pregnancy and sexually transmitted diseases. Beginning in childhood, there is a marked increase in risk for accidental injuries, and that risk continues across the lifespan, resulting in children being twice as likely to die of accidental injuries if they have ADHD before reaching 10 years of age. And in adulthood, adults may be 4 to 5 times more likely to die from accidental injuries, suicide, or homicide by the time they reach midlife. So there are some growing implications that are life-threatening here for the teen and young adult with ADHD. In the United States, as teens enter about 16 to 18 years of age, teens become eligible to learn to operate motor vehicles. And we find that these teens pose grave risks for their driving. Impaired driving is quite common, leading to frequent citations, crashes, and even driving under the influence of alcohol or drugs. As they move through adolescence, we also see an increase in health risks besides the accidental injuries and suicide I've already mentioned, including a growing risk for obesity, in females a growing risk for binge eating or impulsive eating pathology, including bulimia, an increase in risk of dental caries, as well as dental trauma from the accidental injuries, and a growing risk, as I've mentioned, for substance use disorders and the health problems that they pose. Also, over childhood and moving into adolescence, we begin to see the development of comorbid psychiatric disorders, linking up with ADHD. The first among these is usually oppositional defiant disorder, which, if it develops, may also be a harbinger for the development of conduct disorder and antisocial behavior, as well as substance use disorders by adolescence and adulthood. Also, within a few years of developing ADHD, anxiety disorders may begin to emerge, and if ADHD is not treated, this risk of anxiety disorders grows over time, more than doubling by the time the individual reaches young adulthood. There is a small but growing risk for minor depression, such as dysthymia, and even major depressive disorder. And should that develop, that increases the risk of suicidal thinking. Coupled with the impulsiveness of ADHD, The impulsivity may also predict a growing risk for attempting suicide. A small percentage of ADHD children may be so severe in their control of anger and irritability that they qualify for the diagnosis of the new disorder known as disruptive mood dysregulation disorder. There is a growing risk as well for learning difficulties and school performance problems, and of course the developmental coordination problems seen in at least half of ADHD children may continue into the adolescent and young adult years. There is a small but significant risk for intellectual disability and autism spectrum disorder, and clinicians need to be aware that ADHD can in fact overlap with those other disorders. Finally, particularly in teens who have gone on to develop conduct disorder, there is a growing risk for personality disorders by young adulthood, most commonly antisocial personality disorder, followed by borderline personality and then passive-aggressive disorders. About 1 in 4 ADHD teens with conduct disorder may go on to develop one or more of these personality disorders. Now, what does all of this mean for clinical practice and management? First, we have to realize that while ADHD's classic symptoms, particularly hyperactivity, might be declining with age, that does not necessarily mean that the disorder is improving with age, because in its place, we begin to see an expansion of deficits into other aspects of executive functioning and self-regulation, as I've already described. And these problems with working memory, time management, emotion regulation, self-motivation, and others may bring about new impairments in new major life activities. So, on the one hand, classic symptoms of ADHD might be declining, but impairments that are occurring in the lives of ADHD teens may well be increasing as teens enter into new domains that were not previously available to children. We also like parents to come to understand that there is a significant delay in self-regulation, such that they should not view their teenager as being like other teens when it comes to this area of functioning. This explains why the often hoped-for break in parenting, that is, the decline in the need to supervise the child and teen as they get older, because the teen is assuming more and more responsibility for their own self-governance. We see that parents of ADHD teens don't get such a break. Their teen is less mature and requires much more parental supervision, direction, and intervention than do other teens. And this can pose a great deal of stress in families that were expecting a teen to become more self-regulating and independent, and they don't. We also find that parents may experience a regrieving of the diagnosis as these new impairments arise and these new deficits in executive functioning begin to become more prominent. And so clinicians may need to counsel parents on this grief reaction, encouraging them to move beyond it toward acceptance and then working with and advocating for their disabled teen. There are a few issues with regard to medication management that arise during this transition. The greater size of the ADHD teen may mean that medications may have to be readjusted, particularly those medications such as Strattera or the antihypertensive drugs that may have been dosed on the basis of body weight, and therefore those doses might need to increase in an absolute sense. The teen is spending more and more time away from home, outside of parental supervision, perhaps having greater periods of time in work, in school, hanging out with other teens, or more time in the community during evening hours. All of this may warrant moving the teen to the extended release formulations of the ADHD medications if the child was on the immediate release forms, in order to get longer coverage of medication for these symptoms and other deficits across a greater period of time during the day. And in addition, clinicians may need to even add supplemental medication later in the day to augment those extended release medications, should the medication not cover much of those afternoon and evening hours. As I've said, as the teen grows up, there becomes a greater opportunity to participate in other major life activities not available to children. Sexual activity, dating, work, increased independence in the community, and driving are among these and other domains that teens now have access to, and in which we may be hearing reports of impairment that did not previously exist. All of this again argues for using longer-acting medications in approaching ADHD as we do diabetes, as a disorder that requires 24/7, which is to say round-the-clock management every day of the week, and not just in school hours. There is that growing sense of personal autonomy that the teen is developing that may lead to poorer compliance with medications and other treatments, as I previously mentioned. And this may warrant clinicians engaging in a more collaborative relationship or engagement with the teen directly, rather than just counseling parents on what to do about the teen, as if the teen was merely an object of treatment. Now the teen must be viewed instead as a participant, a stakeholder in the treatment process, and may need to be counseled again about their ADHD and its need for long-term management to prevent harm and even death to them if their ADHD goes unmanaged. The growing difficulties with executive functioning include growing problems with emotional self-regulation, and these can lead not just to more impairment in social situations, but in family functioning, in their work life, and in their driving, as I've already mentioned. And should depression develop, it warrants much closer monitoring of the ADHD teen for suicidal thinking and for any comments about potential suicide attempts for which the clinician needs to take immediate steps to intervene. It also warrants consideration of perhaps adding other medications in with the ADHD medications to deal with such difficulties, or with other comorbid disorders besides depression that might be developing in the late child or early adolescent years. So one needs to be sure to select a medication or combination of medications that not only improves symptoms, but also addresses the emotional difficulties and helps to reduce impairments in major life activities. As I've said, there is a growing problem with risky sexual activity, including early starting of sexual activity with others, changing sexual partners more often, not using contraception as much as other teens or young adults, all of which leads to a marked increase in the risk for teenage pregnancies and for sexually transmitted disease, all of which may suggest, again, the need to continue, if not increase, the use of extended release medications for managing ADHD during this critical time of emerging sexual activity. It's not yet clear definitively if these medications in fact do improve this area of functioning, but a few recent studies do suggest that when teens and young adults are on their medication, they are far less likely to engage in risky sexual activity or to go on to have an adolescent pregnancy. Teens, at least in the United States, now have access to driving motor vehicles, and so families must take care to not only educate the teen properly on the safe use of the vehicle, but also find ways to stop the use of internet or other smartphone technologies while driving that can be a great source of distraction and pose harm to the individual for accidents, crashes, or other difficulties while driving. This also means that teens with at least moderate ADHD or higher probably should be put on medication at all times when they are operating a motor vehicle, and should probably be put on a more graduated licensing system, not gaining independent driving privileges quite as early as other teens. Now, the increase in executive function problems and with the impairments that they bring, as well as the move into new school settings, also may warrant a change in medication or an increase in the dose of medication, besides just moving to the extended release forms of medication. Parents now also need to be aware when the teen is away from home that ADHD teens are more prone to engage in substance experimentation and abuse, and need to monitor the teen's peer relationships to be sure that the teen is not hanging around with other more aggressive, more deviant, more impulsive or antisocial peers who are likely to increase this risk for substance experimentation and abuse in the ADHD teen. So closer monitoring of teens with ADHD while they're away from home is highly recommended in order to try to catch and if not forestall this tendency to drift toward antisocial activities and drug use problems or hanging around with other antisocial teens. Research does show that continuing ADHD medications through the adolescent years does result in a reduction in antisocial activities and probably in substance use. Now, if the teen winds up living away from home at a residential high school, or when they move on to college and living away from home there is a small but growing risk that the teen may divert their medication to be used by friends of theirs for studying or staying up late or losing weight or other purposes. And so closer monitoring of the prescription and the medications itself while the teen is away from home may need to be done. Also, it may be necessary to switch the teen from the more abusable Schedule II stimulant ADHD medications to the far less abusable non-stimulant ADHD alternatives, such as the norepinephrine reuptake inhibitors like atomoxetine, or the antihypertensive medications, such as clonidine and guanfacine extended release. In any case, it's at least worth considering these problems with drug diversion and use if the teen is living away from home. The growing individuation of the teen and greater sense of autonomy means also that parents must transition away from more dictatorial or authoritative management of a child to a more collaborative approach to problem solving with a teen. And here there are a number of manuals or books that parents can get access to that teach them how to do this, including my book, Your Defiant Teen, or the clinician's version known as Defiant Teens. Parents must also understand that this delay in executive functioning and self-regulation is going to grow over time, so that the teen is not as mature as others, and therefore should not be granted so much independent and responsible behavior as others when they especially are away from home. In other words, parents need to continue their assistance and monitoring and holding the teen more accountable than other teens as they move into these adolescent years. Entry into new domains of functioning, as I've mentioned, may bring with it the need for additional psychological and psychosocial interventions. I've mentioned the risks around driving, around sex and the need for sex education and contraception education. Perhaps the need to alter dating habits so that teens don't date in couples but in groups that are supervised by parents. And of course, if the teen is working outside the home, that becomes another area of potential impairment that may need some interventions brought to bear. One issue I just want to briefly mention that parents need to be made aware of is the child's growing sense of time and the ability to anticipate the future. As we see on this slide, moving down the slide, we go from the preschool child who has little or no sense of time and the future to the teen and young adult who looks ahead in time and begins anticipating and preparing for the future, what we call in English foresight. And this leads to planning and preparation. The teen with ADHD is going to be much delayed in developing these particular time horizons or this expansion in their foresight, and therefore is not going to be able to anticipate and contemplate the future as well as others, and may need more parental assistance in preparing for the arrival of future events. This can lead to a great deal of conflict, as you see here, where an ADHD teen may only be thinking ahead 1 or 2 days, whereas parents are looking ahead 2 to 3 months and trying to help the teen prepare. And this can lead to a great deal of conflict between the teen and the parents as to what is important for that teen to be doing now to get ready for what is coming next. Parents may also need short-term counseling around that renewed grief reaction, as I mentioned, as well as assistance from other adults in helping the teen when the teen is away from home, such as when they're at participating in sports, so help from coaches, when they're at school, additional help from teachers, or when they're out with other teenagers, where one needs to enlist the supervision of other parents to keep a closer eye on these teens so they don't drift into riskier behavior or antisocial activities. I've already mentioned the need for parents to increase their monitoring of peer relationships and to break up any affiliations with antisocial or deviant peers that may be starting to develop. This may even require that parents move to a different neighborhood and school system so as to expose the teen to more pro-social teenagers that can be a better influence on their behavior. The greater risk of school responsibilities may also bring a greater need for school interventions, such as tutoring in and outside of school, special educational services, using daily school behavior report cards to monitor teen behavior and school functioning, and perhaps even recommending the use of assignment sheets, day planners, and coaching services to help the teen to handle these new demands in school. New therapies may be needed to address the emerging comorbid disorders besides just the ADHD medications. And new psychological therapies may be needed, as I've already mentioned as well, such as collaborative problem-solving training of the teen and their family. Finally, we know that teens who continue treatment through adolescence have less risk for these various impairments that I've already mentioned, and fewer need for mental health assistance, including fewer contacts with hospitals and mental health professionals, if they stay on their ADHD medications. Finally, let me conclude with the fact that we are recognizing that ADHD in teens is a highly impairing disorder. So while classic child ADHD symptoms may be declining, executive functioning symptoms are expanding, and new domains of impairment are becoming available so that the teen may actually be more impaired than are children with ADHD as a result of their unmanaged disorder. Despite all of these risks that I've mentioned, ADHD is among the most treatable psychiatric disorders, having more medications that help more people and improve their symptoms to a greater degree than we see in virtually any other area of psychiatry. So there is a great deal of hope that the teens' difficulties with executive functioning and ADHD symptoms, as well as their new domains of impairment, can be well managed so that the teen can go on to lead a relatively successful and effective life. But we do need to pay special attention to the issues I've raised here that occur during this transition that may warrant changes in our approach to treatment so as to better manage the adolescent with ADHD. Thank you so much for listening to this lecture. Have a good day and be well.